Welcome to the lesson on ulcerative colitis. This is a medium-weighted topic for the exam. Ulcerative colitis is a chronic inflammatory condition and is a lifelong disease where the pattern of inflammation is continuous, extending from the rectum upwards to a varying degree. Have a look at the diagram to understand the terminology which describes the location of the inflammation. Also note the different formulations used to treat the various sites of inflammation. Ulcerative colitis is treated differently based on severity and the site of inflammation. Note that the term subacute refers to moderate to severely active disease which can be managed in an outpatient setting. Let's first look at step 1 on how mild to moderate and subacute ulcerative colitis is treated. Aminosalicylates are recommended as first-line treatment, where rectal preparations are likely to be more effective for patients with proctitis and proctosigmoiditis. Patients who prefer not to use enemas or suppositories are offered oral preparations, although this may not be as effective. A rectal preparation of budesonide, hydrocortisone or prednisolone, or oral prednisolone can be considered when aminosalicylates are contraindicated. In contrast, step 1 in patients with left-sided or extensive ulcerative colitis, is a high induction dose of an oral aminosalicylate, with addition of a rectal aminosalicylate or oral beclomidazole if necessary. Oral prednisolone is used as an alternative in patients who cannot tolerate aminosalicylates. Finally, step 2 is the same regardless of the location of the inflammation. Pause the video and have a look at the diagram to understand all the steps. Acute severe ulcerative colitis of any extent can be life-threatening, and is regarded as a medical emergency. Immediate hospital admission is required for treatment. The first step is to give intravenous corticosteroids such as hydrocortisone or methylprednisolone to induce remission, while assessing the need for surgery. If this is not tolerated or ineffective, intravenous cyclosporin as an unlicensed indication or surgery should be considered. A combination of intravenous cyclosporin with intravenous corticosteroids, or surgery is second-line therapy for patients who have little or no improvement within 72 hours of starting intravenous corticosteroids or whose symptoms worsen despite treatment. Also, note the factors that may increase the likelihood of surgery. Maintenance of remission. Maintenance therapy with an aminosalicylate is recommended in most patients. Corticosteroids are not suitable for maintenance treatment because of their side effects. Oral azathioprine or mercaptopurine as an unlicensed indications can be considered to maintain remission, if there has been 2 or more inflammatory exacerbations in a 12-month period that required treatment with systemic corticosteroids, or if remission is not maintained by aminosalicylates, or following a single acute severe episode.